Just give a few seconds here for people to trickle in, and we can get started. We're really excited for today's webinar. All right, so basically what we're going to do, hopefully everyone can hear me okay, see me okay, and then Margo, who is our guest seminar speaker today, she's going to be leading the charge. She has her presentation up, and I actually just heard her at an industry conference last week, so you guys are in for some really good information. And we know now, you know, with the market where it is, obviously things are kind of very volatile. So we wanted to just start off, or I wanted to start off briefly and just give some remarks on the market, and then we can quickly make an introduction to Margo, and then she can take it away. All right. The 2010s were a decade that was characterized by structurally low interest rates, low levels of inflation, and low stock market valuations coming out of the great financial crisis of 2008. There were no recessions in the US during that time period, and stocks rose at a double-digit clip because of these factors and a material change in the composition of the S&P 500 earnings toward higher growth companies, driving the S&P 500 multiple higher. The COVID pandemic changed the world, and we sit in a different place today than we did pre-pandemic. The pandemic resulted in trillions of dollars of stimulus being poured into the economy and massive global central monetary policy intervention. This, along with supply chain disruptions, have resulted in higher inflation levels. Earlier this year, Russia's invasion of Ukraine further added fuel to the fire, driving energy prices higher and creating grain shortages, even raising the prospect of nuclear war. The Fed was behind the power curve, waiting far too long to raise rates as the economy roared back from the 2020 recession. This exacerbated inflation and even led to a bubble in parts of the high growth market and cryptocurrency space. Now, sitting here today, the market is concerned about the prospect of a global recession driven by global central bank tightening, stimulus checks drying up, and higher energy costs limiting discretionary spending. These are concerning headlines. The market has reacted with a pretty swift decline and a forward multiple on the S&P 500 going from 21 times earnings to a low of 14 times during the June lows, and we are very close to that level now. With the stock market off 23% year to date, the market is now pricing in substantially bad news, though not a truly ugly recession like 2008. History suggests that now is a good buying opportunity. The market is down more than 20% and is pricing in at least a modest recession and/or elevated inflation levels. Buying when the market is down, sentiment is bad, and insider buying is increasing has tended to produce good returns 1 year later. Market downturns are not fun for anyone, and there are real risks that loom. We feel your pain. However, these market downturns can be excellent times to add risk assets when they're on sale. So why then do investors pile into cash, consumer staples, and conservative holdings when the market is down materially? The simple answer is psychology. Investor psychology heavily influences behavior. Even on Wall Street, most investors are trying to win at a game at a very difficult, maybe even impossible game of outperforming over the next day, next week, or month. Over the short term, stocks trade on noise. Valuations are irrelevant and sentiment matters a lot. Most people get caught up in that short-term game, losing focus on where a stock or the market will be 1 to 3 years down the road. This creates long-term opportunities for long-term investors who can ignore that noise. Lastly, there is nothing in your personal or professional life that is pushing you to buy stocks. Your friends, your family, spouse, colleagues, the news cycle are all telling you to reduce risk and prepare for the worst. We cannot predict the future, and we do not know where the market will be in a year, but history suggests that the odds are on our side. Thank you. I know we don't normally do that, but given how extraordinary the times are, I thought spending a few minutes up front giving that address was important. Now I want to introduce our speaker, which on a much lighter note is going to talk about Medicare and Medicare supplemental insurance. Margo Steinlage is a partner and owner in the Steinlage Insurance Agency. And I'm going to turn it over to her to talk about all things Medicare. Take it away, Margo.
Thanks, Josh. I appreciate the time today and the opportunity to speak with your clients on Medicare. Like you said, a little bit lighter than the current status of the stock market. So with Medicare today, I really want to jump into 3 moving parts. You're going to learn a lot about Medicare. This whole presentation will be recorded. Josh will have the link if you email him. He will share this recorded version. Also, we have copies of the PDF of the slides. So if you need that, I can get those over to Josh as well. Just ask him for it. Today, though, we're going to jump in with what is Medicare? What are the rules around signing up for Medicare at 65? And then the second part of the presentation will really uncover the lingo, Medicare Part A, Part B, Supplement, Part C, Advantage. How do these all intertwine? And what is kind of the working components once you're in Medicare? Then lastly, we're going to cover Biden's recent regulation changes. How does this affect your Medicare coverage, your drug exposure called the donut hole, and also income surcharges on your Medicare premiums? A little bit about myself and our agency. I'm from Missouri, St. Louis specifically. We are headquartered in Missouri. We have 2 offices in Virginia, one in Arlington and another in Charlottesville. We have clients all over the nation. So if you live in Virginia, Maryland, DC, if you move to St. Louis, would love that. Or if you move down to Florida or Arizona, we really work with clients nationally. I personally am located here in Virginia and travel back and forth between our 2 offices in Arlington and Charlottesville. All of my services and my team services are free. So once you're working with us, Medicare and Medicare reviews are free to you. We are independent contractors with these national insurance carriers. So we help clients decide if Medicare is the right move. We consult you through that transition when it's necessary. And then we also look at the entire portfolio of product available to you once you are ready to move into Medicare. What's the best product based on your specifics, your doctors, your location, your health, your prescriptions, and make a recommendation regardless of the carrier. We're looking for the plan that meets your needs. And then we're very proactive with our annual reviews. Right now, we're collecting all of our current clients' updated prescription information so that we can make recommendations for this upcoming open enrollment, which runs October 15th through December 7th, which is for when you're already on Medicare. So if you see anything on the TV and you're not on Medicare, this October through December 7th timeline does not affect you if you're not currently enrolled in Medicare. So again, free services. I work with a lot of Josh's clients when they age into Medicare. And again, we're holistic. We really look at your big picture. If you have a younger spouse that's on a group plan, what's your income? What's the price of Medicare? What are the benefits to moving Medicare versus staying on a group plan if you have that opportunity? So let's jump right in. Who is eligible for Medicare? So I generally say the rule of Medicare is that once you're turning 65, you need to sign up for Medicare Part A and Part B. That's the general rule. If you don't sign up for Medicare at 65, then you're going to get hit with a penalty and possible gaps in your coverage. So the general rule, 3 months before your 65th birth month, you need to start your Medicare application for a Medicare effective date of the first of your birth month. So if you're turning 65 January 2nd or January 22nd, you need to start your Medicare enrollment in October for a January 1st effective date. You have all of October, November, and December to sign up for that January 1st effective date. The exception to that general rule, you need to sign up for Medicare at 65 to avoid penalties, is if you are working after 65. If you or your spouse are working with a large employer, the size of your employer who offers you the group coverage is the determining factor on whether or not you need to take Medicare Part A and Part B at 65. So if your employer has 20 or more employees, then Medicare becomes optional and you do not have to sign up for Medicare at 65. So if you or your spouse are working for a large employer and that large employer is covering you and your spouse with group coverage, then Medicare is optional. The 20 employees can either be full-time or part-time. Not all of the employees have to be enrolled in their health plan. What Medicare is looking at is the size of the employer, whether it's full-time or part-time. That combined number needs to be over 20 or more, then Medicare becomes optional. If it's fewer than 20 employees, 19 employees, then Medicare is required. And you need to sign up for Medicare upon your 65th birth month to avoid any penalties or gaps in your coverage. So if you have a small employer through your employer or your spouse's employer, and that small employer is offering you group coverage, then Medicare needs to be the primary payer. Medicare is required at 65. Note, if you do have large employer coverage and you're on a large employer plan through your work or your spouse's employer, you can keep that, you can delay Medicare. The next part of the equation is, do you have an HSA component that you or your spouse are contributing into? If sometimes your employer will contribute into that HSA, health savings account. If you are on large group coverage and you continue making contributions into your HSA, or your employer is making contributions into your HSA, you need to delay both A and B upon turning 65, because Medicare and IRS do not allow you to make Medicare or HSA contributions and sign up for any part of Medicare, the free Part A or the Part B component. So we're in the weeds here. Let me repeat everything. If you are working with a large employer and you have an HSA tied to your group plan, and you or your employer are making contributions into that large employer plan's HSA, you need to delay both A and B to avoid any penalties from IRS and Medicare. Once you decide to retire and come off of that large employer plan, you need to cease your HSA contributions 6 months out from your Medicare enrollment. So generally for clients, I recommend connecting with somebody like myself, a broker, 6 months prior to turning 65 to create your game plan. Do you need Medicare? Do you not? And then if you can delay Medicare because you're on a large group plan, I recommend reaching back out about 6 months out prior to your desired retirement date so that we can coordinate this HSA component, the Medicare enrollment, and your plan selection. So HSA and that Medicare enrollment can have some red flags to watch out for with that 6 month retroactive look back and start date. When you submit your Medicare A and B paperwork, Medicare Part A will have a 6 month retroactive look back on its effective date, which can affect your HSA contributions. So again, very few people will have this situation come up, but working with financial advisors, I see this pretty frequently. So I'm just putting that out there on your radar. Again, general rule, you need to sign up for Medicare Part A and Part B upon turning 65, unless you're on large group coverage then it becomes optional. You can delay Medicare Part A and Part B until you're ready to retire or your spouse is ready to retire. Now you can come off that group coverage, that large employer plan, and move right into Medicare Part A and Part B without any penalty. If it's a small employer, you need to sign up for Medicare. Also, if you do have HSAs that you've funds that you've accumulated over the last few years, you can use those funds for basically everything in Medicare, for medically qualified expenses like income surcharges, Medicare premiums, drug plan costs, dental costs, vision, hearing. The only thing that is not allowed with the HSA funds is your MediGap premiums. You cannot pay your Medicare supplement, also known as MediGap. You can't pay those premiums with HSA funds. IRS does not allow that. It's not a medically qualified expense. Everything else, Medicare Part B, any IRMAA income surcharges, prescription costs, dental costs, and any premiums on your dental plan, drug plan, Medicare are all medically qualified expenses. And you can use HSA funds for those medically qualified expenses. So what is Medicare? Once you are ready to enroll in Medicare, whether you need to at 65 because you're not on large group coverage, or you're delaying Medicare and now you're ready to retire at 68, 69, 70 and come off that large employer plan and pick up Medicare A or B, what are those moving parts? What is that coverage? So when you sign up for Part A and Part B, you're going to get a red, white, and blue card that shows Part A hospital benefit and Part B medical benefit. So Medicare, original Medicare, consists of two moving parts, Part A hospital and Part B medical. Part A hospital is generally a zero premium because you or your spouse worked for 40 quarters, which amounts to 10 years, and you paid into the system, and now you reap this zero premium hospital benefit. Note that if you do not have the full 40 quarters of work history, you can tap into your spouse's work history to get to 40 quarters. Part B, boy medical benefit of Medicare, has a standard Part B premium, and this year it's $170.10. Medicare announces their upcoming year's changes in late October to early November. There's word on the street that the Part B premium for 2023 will stay the same, but again, we'll have that definitive answer later in the fall. So right now, everybody who signs up for Medicare will get assessed a Part B premium of $170.10. This is income-based. Part B premiums are based on your prior 2-year tax return. This is called IRMAA, income-related monthly adjusted amount. So Medicare Part B and that standard premium is adjusted based on your prior 2-year tax return. I'm going to discuss IRMAA and this income surcharge later on in the slides, but be aware when you sign up for Medicare, what you made in adjusted gross income in the 2 years back will affect your current year premiums for Medicare. Medicare is income-based. Once you sign up for Part A hospital and Part B medical and you have your red, white, and blue card, what does that get you? Let's say you sign up for Medicare January 1st and you go into the hospital January 5th with just a red, white, and blue card, Medicare. When you go into the hospital, Medicare has a Part A hospital deductible of roughly $1,550 for the 60-day occurrence period. So you go in January 5th to the hospital, and then you go in again June 7th. You're outside of your 60-day occurrence. That deductible resets every 60 days. So you go in January, you pay the $1,500 up front. Then you go again in June, you pay $1,500 again. Medicare has a medical Part B premium, or I'm sorry, deductible of $233 per year. Once you go in and see your doctor for blood work, routine visits, x-rays, PT, outpatient surgery, you're paying the first $233 for the year. Once you satisfy that, basically with a doctor visit, then Medicare will pay 80%, you pay 20% of those medical claims. There's no cap or ceiling on your 20% exposure. This is where all of the ancillary products, like Medicare supplements, like Medicare Part D drug plans, like Medicare Advantage plans, Part C, they come in to fill these gaps of original Medicare, because original Medicare has your Part A deductible and your Part B deductible, and that 20% exposure with no cap or ceiling on your out-of-pocket exposure. That's where we come into play. To fill these gaps in original Medicare, there's really two routes that you can take. You can go with option one on the left side of the screen here, original Medicare with a Medicare supplement and a standalone drug plan. You can add dental and vision to this package as well. If you choose option one, original Medicare plus your MediGap supplement plan, plus your drug plan, plus any dental or vision, you're going to have comprehensive coverage. And you're paying that Part B standard premium of $170.10 per month, plus your supplement and drug plan premiums. The alternative route on the right side of your screen here is option two, Medicare Advantage, also known as Part C. If you choose Medicare Advantage Part C, you still pay the Medicare premium of $170.10 plus any IRMAA. So the common denominator here is no matter which route you go, supplement and drug or Medicare Advantage Part C, you still are required to pay your Part B premiums plus any income surcharges, IRMAA. Let's dive a little bit deeper into the pros and cons of each option. If you go with original Medicare plus a supplement and a drug plan, you have nationwide coverage with any doctor that takes Medicare. So there is no network. You never ask, do you take United Healthcare supplement? Do you take Anthem supplement? Do you take Care First supplement? The question to always ask is, does your provider take Medicare? If you're traveling, your supplement and your Medicare follows you nationwide. There's no need for referrals, no prior authorizations. It's you, your doctor, and Medicare. When you pick up a supplement, there's a range of supplement letters, Plan F, Plan G, Plan N. All of these types of supplements, also known as MediGaps, all of these supplement MediGap plans will come in and fill the gaps of original Medicare. So depending on your plan letter within the supplement market, if you go with a Plan F supplement, regardless of who the carrier is, a Plan F with Aetna and a Plan F with Cigna and a Plan F with United Healthcare is identical in benefits. The difference is in the monthly premiums at which it's offered. Your Plan F supplement covers 100% of the gaps of original Medicare. Plan F covers the Part A deductible every 60 days, the Part B deductible every year, and that 20% coinsurance. You show your Medicare card, you show your Plan F supplement card, regardless of the carrier, that combination has 100% coverage with any doctor that takes Medicare for any Medicare approved charge. Right now, Plan F is not available if you turn 65 on or after January 1st of 2020. The next best option that's available based on regulation is a Plan G as in girl. Congress basically came in January 1 of 2020 and said, no plan, no supplement plan can cover 100% of the gaps in Medicare as of January 1 of 2020 and beyond. So Plan G, girl, came on to abide by that regulation. Like the Plan F, which covers 100% of your Medicare gaps, Plan G as in girl is right underneath that Plan F. Plan G girl supplements, regardless of the carrier, Plan G girl will come in and cover 100% of your gaps in Medicare, except for that Part B medical deductible of $233 per year. So you show your Medicare card, you show your Plan G supplement card. That combination gives you 100% coverage nationwide with any doctor that takes Medicare, except for a $233 annual deductible. Once you pay your deductible, Medicare and your supplement are paying 100%. Plan N, Nancy, is one step down from F and G. Plan N, Nancy, will cover 100% except for the $233 medical per year Part B medical deductible. And you'll have $20 copays for primary visits and doctor visits and specialist visits, $50 ER copays. And the biggest gap with a Plan N is called Part B excess charges. B as in boy, excess charges. If you go to a doctor that takes Medicare, doctors can either agree to Medicare reimbursement rates and charging. This agreement to the reimbursement rates of Medicare is called assignment. If doctors take assignment, they can't charge more than Medicare sets for services. If doctors are non-assigned with Medicare, they take Medicare but are non-assigned, then they can charge the patient, they can balance bill the patient legally up to 15% above what Medicare approves. So if your doctor is assigned and Medicare approves $100 for a doctor visit, your doctor will charge your supplement $100. Medicare and your supplement pays the $100. If your doctor is non-assigned, then that carrier, that doctor can balance bill you 15% above what Medicare reimburses. So if Medicare reimburses $100, your doctor can balance bill you 15%, or $15 in this example. Plan N, Nancy, does not cover that balance billing. Plan F and Plan G covers the balance billing. So if you ever are balance billed, your Plan F and Plan G protects you. Plan N does not. I say all of this, Mayo Clinic is a perfect example of a real life provider that does not accept Medicare assignment. They can balance bill patients. And if you have a Plan N, you are exposed to that balance bill of 15%. Plan G and Plan F cover you. So depending on the supplement structure that you choose, F, G, N, you have a level of protection. All of these supplements, an F is identical carrier to carrier, a G is identical in benefits carrier to carrier, same with N. So when you're choosing the carriers, what we are looking for is who has competitive rates at the age you're entering, 65 or 70. Also, who has competitive rate structure? Are they, how do they rate their policy? Are they attained age, issue age, community rated, etc.? What's their rate increase history? All of these things we are factoring in to select a premium payment and supplement plan for you when you're turning 65 or you're aging in with a later retirement. Once you set your supplement, in most states, Virginia, Maryland, and DC are included in this. If you want to rate shop your supplement, if you want to go F to G, G to N, carrier to carrier, you are required to answer health questions when you're outside of your Part B enrollment period. So when you're turning 65 or coming off your group plan later and picking up Part B, you have a 6-month kind of guaranteed issue period where every supplement plan will take you without health questions. When you're outside of that 6-month guaranteed issue period, these supplement plans will require underwriting and require answering of health questions to get you approved. So once you set your supplement, if in most states, if you want to change that supplement at a later date, you are required to go through medical underwriting and get approved with the new carrier. The supplement market is the one market that ACA health reform did not touch, and supplements can still look at pre-existing, they can still require health underwriting. So once we set your supplement, we're also looking at your prescriptions year after year. And we're choosing a Medicare Part D drug plan. In Virginia and Maryland, DC, there's about 30 different Part D drug plans that are on the market. What we are looking at is your premium, your copays on your current prescriptions, the deductible, what's your total cost, which of the 30 plans is giving you the most competitive rate on your total cost per year. And again, we're proactively looking at that every year during this open enrollment. The drug plans, unlike the supplements, we can rate shop your drug plan and go Part D plan to Part D drug plan without any underwriting or issues for a January 1st effective date each year. Hey, Josh, I have a question up here that I'm not able to see.
Yes, would you like me to read it?
Yeah, that would be great.
Okay, sorry about that. All right, so the question is, I received a survivor benefit from the federal government and also pay for medical insurance. Medical insurance, Blue Cross Blue Shield at the moment. Through that benefit, I have Medicare Part A and B and assume the additional Blue Cross Blue Shield medical insurance serves as supplemental insurance to Medicare. Is that correct?
Correct. So this presentation does not, if you're a federal employee and you have federal employee health benefits through your surviving spouse status or your retiree status, that is very similar to the supplement market. We don't touch on federal benefits. This is more for private individuals coming off private employer plans or Obamacare individual plans. But if you are a federal retiree or have access to the federal retiree plan, then that type of product is very comparable to the supplement and drug plan. You don't need MediGap Part D or Part C. You're going to hang tight in your federal employee health plan or GEHA plan. I hope that's clear. Okay, perfect. So with this original Medicare supplement and drug plan combination, it's Cadillac coverage. You are guaranteed for life. The only way a supplement plan can come in and cancel you is if you fail to pay premiums on time. So excellent coverage. If you wanted to add dental and vision, that would be a separate policy that we can also put in force. Again, the beauty here working with a broker like Steinlage is we really are manipulating your portfolio, your supplement, your drug plan, your dental vision, based on the competitiveness of the market. If you have a husband and wife both on Medicare, you're likely going to have the same supplement, but you could have wildly different drug plans because you're on different prescriptions. Just a good example there. Another question here.
I have Part N. Can I change that in the future? Same question with the drug plan, question mark.
So the Plan N, if you're in Virginia, Maryland, or DC, most states, you can change, but you have to answer health questions to go from Plan N to Plan N or Plan N to Plan G. So anytime you want to rate shop, that's fine. We can do it anytime throughout the year, but you are required to answer health questions. And depending on your health in the last 5 years, and if there's anything pending, PT, surgery in the next few months to year, you can be denied and you're stuck in that Plan N supplement carrier that you currently have, which isn't the worst thing. You may pay higher premiums, but you still have decent coverage. For the Part D component, we can rate shop every year in October. during that open enrollment period without any health questions, without any issues. You can move drug plan to drug plan, and that new drug plan carrier is required to take you, and it will go into effect on January 1st.
Thank you.
Also Plan N and G and F, they all include foreign care benefit up to 80% off up to $50,000 lifetime maximum. If you need access to travel care and you want to get a policy, we just had a not new carrier, Anthem, Blue Cross. It's called Geo Travel. It's a brand new product. It's great for expats. If you want to move overseas for a few years, they cover both in country and also out of country. They have a couple of hybrid policies. So if you need good travel insurance, we have a new product that is excellent for anyone looking to travel overseas and get more robust coverage. Okay. So that was option one, original Medicare plus your supplement. You show your Medicare card, you show your supplement card, whether it's F, G, or N, you're going to have great coverage with all three of those packages. The alternative is called Part C, original Medicare, or Part C Medicare Advantage. When you sign up for a Medicare Advantage plan, you are selecting an HMO or a PPO Medicare Advantage Part C plan. Part C, regardless if it's HMO or PPO, combines Medicare A, B, D, dental, vision, hearing, drug, gym. They combine all of your types of coverage into one bundled managed care policy. You show your HMO card for all drug pickups. If you go to the gym, you're showing your HMO card. If you go see a dentist, you're showing your HMO card. If you go see your primary, you're showing your HMO card. If you need to see a specialist, most HMOs require a referral. With the PPO, again, you're showing your PPO card for everything. You do not need referrals when you show your PPO card to a specialist. The HMO and PPO in this area are generally zero premium per month. You're still paying your Medicare premiums plus any income surcharges, but your actual policy is a zero premium. Most have a zero deductible. So when you start using or needing care, you go in and you pay a zero copay for a primary, $35 for a specialist, $90 for an ER, $200 to $300 for a hospital stay per day, 20% for a MRI. You have set copays that you pay under your HMO rules or your PPO rules up to your plan's max out of pocket. Depending on your state, these plan max out of pockets vary greatly. In Virginia, they tend to stay at like the $4,000 to $7,000 out of pocket range. So when you are paying all of your copays for services rendered throughout the year, and let's say you have an awful year, you flirt with that max out of pocket of $5,000. Once you hit your plan's max out of pocket, now your plan pays 100% for the rest of the year. So the beauty of these advantage plans, or the attractiveness, the advantage to advantage plans, is that they are an easy way to save money. But on the back end, if you have a really bad year, you could come out of pocket $4, $5, $6,000 and hit your max out of pocket for the year. Also, these plans are networked. So if you want to go to a specialist out of state and you have an HMO, you're generally locked into your HMO's regional network. You can't go out of the state for non-emergency cancer treatment. If you are traveling and you have an HMO, you do have emergency room coverage nationwide and urgent care coverage nationwide, but non-emergency, non-urgent coverage is not allowed under an HMO. With the PPO, it's kind of the hybrid of advantage and supplement. The PPO generally allows you to go nationwide to any doctor that takes Medicare, but you'll have higher out-of-pocket exposure for that out-of-network exposure. or out of network usage. So if you are somebody who has a larger appetite for risk, you forecast that you're going to stay healthy for the long haul, and you don't mind these limitations of networks and copays, prior authorizations, and you're looking at bottom line and premiums, then the Advantage plan is pretty attractive. 0 premium plus all the extra dental, vision, hearing, gym built in. If you are somebody that wants the protection and the benefits and you're willing to pay up in premiums, then that supplement is really going to protect you and limit your out-of-pocket exposure year after year. But you're paying for it with the monthly premiums. The biggest part of this equation is that your initial decision can have some long-term consequences. Remember, regardless of the route you take, if you go supplement or Advantage Part C, you are still paying that monthly standard Part B premium and any income surcharges to Medicare. So there's no wiggle room to avoid that. But if you go Medicare Advantage when you first become eligible for Medicare, so if you're turning 65 or you're coming off large employer coverage and you elect a Medicare Advantage 0 premium PPO now, when you become eligible, and 2-3 years you say, Margo, hey, can you move me to a supplement? I'm really, sick of my Advantage plan, or I'm sick and I'm hitting my plan's max out of pocket. I want to move to the supplement for better coverage, less out of pocket exposure. This is when your supplement will say, hey, you're unhealthy, answer our health questions. You're too high risk, we're going to deny you. You can't enter the supplement market. You're restricted to your Advantage plan market now. You can shop HMO to PPO, PPO to HMO, carrier to carrier without any health questions, without any restrictions every year in the fall. But as soon as you want to drop your Advantage plan and move to that Medicare supplement product, you are required to answer health questions, which you can pass if you're healthy. You haven't been in the hospital. There's nothing on your file that shows arthritis, COPD, osteoporosis, any heart issues, thinner medications usually trigger a red flag on underwriting. So if you're healthy, you can move back and forth. You can shop your supplements. You can drop your Advantage, move to the supplement. But if you're unhealthy, which is a pretty vague term here, if you can't pass medical underwriting, then you are limited to your Medicare Advantage product, which we can shop year after year. If you choose the Medicare supplement product when you first turn 65 or become eligible for Medicare, and you want to drop your supplement, you call me 4 years from now and say, Margo, I'm sick of paying these premiums. They've increased 3% every year, 7% every year. I want to drop it and move to an Advantage plan. We can move supplement to Advantage plan without underwriting. That's a very easy move to make. Your Advantage product, regardless of the type of product, is required to always accept you. However, if you choose supplement when you first become eligible, and now a year or two later, you want to rate shop your supplement in most states, including Maryland, Virginia, DC, in most areas, you are required to answer health questions to rate shop your supplement, G to G, N to G, G to N, etc. The drug plans, no health questions to rate shop year after year. So again, takeaway from this slide is that your initial decision will have long-term consequences because of this underwriting review. So here are your review periods. Once you are on Medicare, October 15th through December 7th is when we review your drug coverage or your Advantage plan. The supplements we can review anytime throughout the year. There is no limit or restriction on when you can change your supplement, go carrier to carrier, plan to plan. We can move you, but you're always subjected to health questions. The annual enrollment period, October through December, no health questions to shop your drug plan to new drug plan, no health questions to move Advantage to Advantage plan. Okay, there is one more question here, Josh. If you could read that out loud for me, that would be great.
Please address TRICARE for Life as Medicare supplement. Thanks.
Okay, so TRICARE, again, we don't work with the federal retiree benefits, but TRICARE, once you're ready to come off into Medicare, same general Medicare A and B rules, you need to pick up Part A and Part B, and then TRICARE for Life is just like a supplement F and a top drug plan. TRICARE for Life includes your supplemental and your drug plan coverage and works in that capacity. So you show Medicare, you show your TRICARE for Life plan. That's your combination. You don't need the supplement, the drug plan, or Part C option. Call TRICARE for Life. They'll walk you through the eligibility and your specific circumstances. But you do have to have Part A and Part B to trigger that TRICARE for Life as a secondary.
Another question, Margo.
Mm-hmm.
If I spend part of the year in Florida and part elsewhere, is Advantage or supplement better?
It depends. So that's where I would look at the 2 states that you're spending your time in to see what's the supplement rates, the premiums. If you're on the fence, supplement and Advantage, we would definitely look at a PPO on the Advantage product. That would give you flexibility to go Florida and your current state. You can go nationwide to any doctor that takes Medicare. So we would look at that product. And then we would also look at your 2 states, the supplement premiums, to decide which state gives you the best supplement rates. And then we would really dive into, do you want Advantage or do you want supplement based on the competitiveness of your 2 states?
Yeah.
So Margo, I can't answer that, but it depends on your
but I just, one of the kind of threads I pulled away from the presentation you gave last week, and maybe you could talk a little bit about it, was just the flexibility of coverage and robustness of coverage of the MediGap supplemental plans versus the Advantage. I mean, is the PPO within the Medicare Advantage? I just want to make sure, because some of these clients are used to total coverage and flexibility. So
yeah, so to answer that question again in a different way. So if you want the best coverage that you can get where you're traveling in and out of states and you want limited exposure, meaning I don't want to pay copays, I don't want networks, I don't want any headache, the supplement route is going to be the best plan for you across the board. You're going to pay for it depending on the state's premium, but when you go see your doctor in Florida, California, Virginia, you're going to have close to 100% coverage with your supplement product. So in that equation, we would look at the states that you have houses in, and we would select the most competitive supplement premium. And knowing that you have excellent coverage, that supplement premium will cover you more or less at 100%. The Advantage PPO product allows you to go nationwide. You pay $0 for it, but if and when you have an issue, you're going to Florida or Virginia doctor, you're going to have a copay or a cost that you're getting billed for from your PPO plan. Whereas if you went supplement, there are no bills that you receive. Medicare and supplement are paying pretty darn close to 100% coverage. So if you want headache-free coverage and you're willing to pay an extra $100, $200 a month in premium, the supplement route's the way to go.
Thank you.
Okay, so IRMAA, as I discussed in the beginning, everyone has that standard Part B $170 and 10-cent premium. That's set by Medicare. Medicare is using your prior 2-year tax return. So if you're turning 65 in 2022, Medicare will use your 2020 modified adjusted gross income for the household. So if you're filing jointly, you have a modified adjusted gross income that's a joint figure. Medicare is looking at your joint modified adjusted gross income from 2 years back. If you're filing as a single tax filer, you're in a separate bracket. Medicare is still looking at your single modified adjusted gross income from 2 years back to set your current 2022 premiums. So Medicare sees this high income on file 2 years ago because you or your spouse were working. If you retired in 2020, 2021, 2022, and it leaves you with a lower anticipated income, modified adjusted gross income, Medicare has no idea that you've retired, you've had a life event. You can appeal Medicare IRMAA surcharges and ask Medicare to reduce your income surcharges, your IRMAA, based on your life event retirement, and it leaving you with a lower anticipated income for that year or the upcoming year. So if you're retiring January 1st of 2023, Medicare will automatically update their figures from 2022 to 2023 with your prior 2-year tax return. So in 2023, Medicare is looking at your 2021 modified adjusted gross income. If you retire in 2023, Medicare doesn't have access to that. So we go through this appeal process, which is pretty easy. Medicare just needs a letter from your employer stating work stoppage, work reduction. Once you submit that form and your letter from your employer stating that I have lower anticipated income for my retirement year, Medicare will reduce your IRMAA and use your anticipated retirement year income rather than your high earning years income from 2 years back. So Medicare is constantly updating their information every fall based on your prior 2-year tax return. So in 2025, Medicare will automatically update your information on file with your 2023 modified adjusted gross income that they get from the IRS. Let me go back a slide to the IRMAA brackets. So you'll see here, if you retire and you take a very high payout, let's say you're retiring 2023 and your company pays you $1 million to exit, you're going to get put in your 2023 modified adjusted gross income will be very high. So in 2025, that can affect what you're paying in Medicare premiums pretty drastically. You'll see here in the gray columns, that is your the first gray column, Part B premium plus IRMAA, is your standard $170.10 premium plus the income surcharge, which you will pay. Then in the last column there, Part D IRMAA, is your income surcharge that is added to any Part D drug plan or Part C drug component that has the drug plan built in. You're paying both a Part B IRMAA and Part D surcharge IRMAA. The only way to appeal this and request a reduction is if your life event retirement leaves you with a lower income for the retirement year. If you had a home sale in 2021 or 2022, if you had a high capital gain, an investment that brought you up a benchmark, not your working income didn't bring you up, but that capital gain brought you up, there's no way to appeal that based on the retirement. Medicare will see that you had a higher income that year, higher modified adjusted gross income that year because of a home sale or a capital gain or an investment. So anything you're doing now will affect you 2 years down the road income-wise. And again, Medicare updates that information automatically year after year. Any questions on that, Josh?
There is a question that came in more kind of holistic, but I can go ahead and ask it if it's okay in your presentation.
Yeah, that's fine.
Okay. So if I'm hearing you correctly, if you have pre-existing conditions that are likely to only cause your health to get worse, that you should get into Medicare Advantage plan.
No, I would go Medicare supplement, knowing that you can never answer health questions to get into the supplement outside of your initial enrollment. So if you know you're going to use care, you're going to hit your max out of pockets every year, then I would go with a supplement, Plan G or Plan N, likely Plan G, because there's no medical underwriting when you first become eligible for Medicare. So if you're turning 65 or you're coming off large group, you sign up for Medicare, you have this 6-month window to select your supplement with no underwriting or health questions or pre-existing limitations. So you're able to get into the supplement and get the best coverage. You're going to pay up front for it for the monthly premium, but you're locked in with the best plan, and that is guaranteed for life so long as you pay your premiums. So if you know you're going to use a lot of care and your health's going to decline, you have Alzheimer's, supplement. You need dialysis, supplement. You want the supplement for the best coverage that you can get. You'll more or less, if you go G, you're going to have 100% coverage with that combo, Medicare plus your supplement G girl. Your only exposure there is a $233 medical deductible. But you got to get in when you're first eligible for Medicare. If you went Advantage plan, you would pay up to $5,000 in out-of-pocket exposure every year because you're hitting your plan's max out-of-pocket, potentially, because of your health. So I wouldn't recommend that route. If you're extremely healthy, you have a large appetite for risk, and you know the long-term consequence of going Advantage, the consequence being you can never go to a supplement if you become unhealthy, then the Advantage plan is attractive. Most of my clients, just to give you guys a perspective here, most of my clients in the DMV region go supplement. The Virginia, Maryland Medicare Advantage product is not nearly as competitive as what we see in like Florida, the Midwest, down south, because the Maryland, Virginia, DC max out of pockets on these Advantage plans are very high, $4,000, $5,000, $6,000, $7,000, $11,000 if you're out of network. Whereas down in Florida and Missouri, they're at like $2,000 max out of pocket. So it's a little bit more favorable to go Advantage in some circumstances. But again, here in the DMV, I would say at least 80% of my clients go supplement because it's more competitive on price and benefits when you're looking at the whole package. And again, my recommendation is, after an hour of talking with you, looking at your intake form that you complete for us, looking at your prescriptions, your health, the recommendation really is on a per client basis. I can give general 80% of my clients go supplement in this market, but really what I sit down and look at, and my whole team, we have plenty of brokers who do exactly what I do. Our whole team is really looking at your specifics to give a recommendation or consult you. Do you need to take Medicare? Once you need to take Medicare, what are your options? What's the best direction based on your specifics that you're telling us? So last part of the seminar here, Biden on August 16th announced the Inflation Reduction Act, which has a great drug plan component to it. So basically, the changes that are happening in 2023 based on this recent law. In 2023, no matter which direction you go, supplement and drug or Medicare Advantage, you're going to have 100% of vaccine coverage under Part D. So if you go get your shingles shot in 2023, you're going to have 100% coverage, whereas in the past, clients paid like upwards to $1,000 for their shingle vaccines under Medicare. So that's the biggest change for 2023. Then in 2024 and 2025, the donut hole is closing and there is a cap on drug plan out of pocket. So under all Part D components of Medicare, if you're on TRICARE or federal employee health benefits, you're a federal retiree, this does not apply to you. But under all of the Part D components and all of the Part C components, Medicare has the same rules for all of those plans. There's different stages of drug coverage built into these plans. So when you go in and you fill your medications under Medicare and these private plans, Generally, you'll have a deductible. You go pay the full cost of your meds under your deductible. Then you're going to have a flat initial coverage phase where you're paying a flat copay on your medications. If you're on Eliquis, it's a $600 medication. You pay a $42 copay under this initial coverage stage. What your drug plan and Medicare is calculating in the background is how frequently you're filling your meds and the cost of all meds being filled throughout the year. Once your total out-of-pocket costs and all meds being filled throughout the year reaches $4,600 roughly. Now Medicare and your drug plan backs away and says, hey, instead of paying a flat copay, you are now in the coverage gap phase, also known as the donut hole, and you pay 25% coinsurance rather than a flat copay. So as soon as your retail cost of all meds being filled throughout the year reaches that $4,600 benchmark, you go from paying roughly flat copays, low copays, to a 25% coinsurance on these expensive medications. This is where your exposure gets heightened. So Eliquis, you're paying 25% of the cost rather than a $42 copay. If you're on a $1,000 med, 25% in the donut hole needs a $250 copay. So this is a substantial gap in Medicare. To get out of this donut hole coverage gap stage, 25% exposure, what you've paid in deductible stage, copay stage, initial coverage phase, and the 25% coinsurance, the coverage gap phase, once you're true out of pocket, what you're paying in deductible, initial coverage phase, coverage gap, once that meets $7,400 for the year, you're now taken out of that donut hole with a 25% coinsurance exposure into catastrophic coverage phase. This is where Medicare and your drug plan comes back. Medicare and your drug plan pays 95%. You pay a 5% coinsurance rate on your medications for the rest of the year, every month for the rest of the year. So if you're on a $1,000 medication and you're filling that retail cost med every month, by the 5th month, you're in the donut hole. You continue filling the 25% coinsurance rates, you now exit that donut hole and you get into catastrophic coverage land, paying 5%. I go through all of these stages because Biden's Inflation Reduction Act changes this. So in 2024, Medicare is eliminating this 5% coinsurance stage. So once you're true out of pocket, what you pay in deductible, what you pay in initial coverage phase, and the 25% coinsurance in the donut hole, once that meets the $7,400, you are now capped at your exposure. $7,400 is not what you pay, it's like what everybody's paying combined. Deductible, initial coverage stage, 25% coinsurance, and this opaque manufacturer's discount is being added in. According to Medicare, the average exposure here to get out of the coverage gap is about $3,800 with all of these true costs being added in. I know this is very confusing stuff, but for 2024, your worst case scenario in drug exposure is $3,800 to get you to that catastrophic level. Then Medicare is capping you, no more exposure. In 2025, Medicare is capping everybody at $2,000. So it basically eliminates the donut hole. If you have a very expensive medication and you go fill it in January of 2025, you come out of pocket $2,000. Now 100% is covered for the rest of the year. If you're not on expensive medications, you're still paying the deductible or the simple coinsurance that's set on your medication. So this is huge regulation. We've been looking forward to this regulation for many years. I work with 10 clients a day in this arena, and we see a lot of expensive medications come across our table. This will protect a lot of seniors with their expensive medications. Also, if you're on insulin, that law caps insulin at a $35 copay as of 2023 throughout all stages of Medicare. So deductible, initial coverage, coverage gap, $35 flat copay on insulin. Excellent, excellent, excellent regulation with the Part D consideration. What we do forecast happening is an increase in the Part D premiums down the road because they're taking on more risk with those caps coming in. So we're going to see higher premiums likely on the Part D plans. Right now, there's $7, $10, $15 Part D plans. We'll likely see those increase to offset that drug plan's exposure and risk. Again, very specific on your medications. If you're not on expensive medications, you won't experience this donut hole. It's a moot point. If you are prescribed a very expensive medication, you'll flirt with this donut hole, this coverage gap, and you'll feel the pain of the coverage gap and higher expenses on your drug copays. Again, this law is taking effect in 2024 and fully in effect by 2025 with that $2,000 drug cap. So what to take away from this presentation? It's pretty dense. Everyone has a unique situation. There is no one size fits all with a Medicare consultation. We do this nonstop, 8 o'clock to 5 o'clock. I have a whole team here. So if you have any questions, there is no dumb question in Medicare. We see it all. Feel free to connect with Josh, myself. I use Josh a lot if you're high income and you have these Medicare IRMAA surcharges. We like to coordinate with financial advisors and accountants to make sure we're getting accurate figures to assess and estimate what you will pay in Medicare. Again, start this process early, even if it's a year out. Get a good idea as to your game plan, your plan of attack for your 65th birthday, so that you avoid the red flags. You know what to take away. If you're staying on your group, if you have a younger spouse, children on the plan, you know what to do when you're encroaching that 65th birthday. Because come 65, 6 months out from your 65th birthday, you are going to be bombarded with solicitations, mailers. Everyone under the sun wants to talk to you. So do yourself a service, get educated, know what to expect well in advance of that 65th birthday. Any questions? I'm here. Josh is here to help coordinate as well. But thank you guys for the time. Josh, thank you so much for the opportunity to help your clients out. I really appreciate it.
Thank you, Margo. You are truly the Medicare guru, and we're just so happy that we've been able to connect with you. And all of our clients who've worked with Margo have had a really positive experience. So thank you, everyone, for attending. Hopefully you got all of your questions answered. But again, Margo's available. I'm available. So if there's any follow-up, please let us know questions you have. And again, this webinar is being recorded, so we'll make sure to send it out to everyone as well.
All righty.
Thank you so much, Margo.
All right. Bye-bye.
Bye-bye.